Heart failure is incredibly common today. We know that over 6.5 million Americans are living with heart failure. Among those, there are two main types that we talk about: heart failure with reduced ejection fraction, or HFrEF, or heart failure with preserved ejection fraction, or HFpEF.
Essentially, heart failure with preserved ejection fraction is the idea that your heart muscle is stiff. The heart muscle squeezes normally, or relatively normally, as opposed to heart failure with reduced ejection fraction where it doesn't squeeze normally, but it doesn't relax normally. And it has to relax normally in order to let the blood in, to let the blood, pump out. We're increasingly understanding over the last decade just how sick individuals with heart failure with preserved ejection fraction can be and just how common it is. But I have to say, we still don't know the exact prevalence because it's so underdiagnosed. Patients with HFpEF live in primary care clinics mostly. Whether we recognize that they have HFpEF or not, that's where they are.
One of the major goals for the next 5 to 10 years is really empowering primary care physicians to really understand, how do we diagnose the breathless patient with heart failure with preserved ejection fraction when there's not that one slam dunk thing on the labs or the echocardiogram that they can really rely on all the time. But the other thing that I want to make sure providers know is that the future is very bright for HFpEF. For years, we didn't have anything. Now, just in the 2020s, we have real successes of medications that work.
SGLT2 inhibitors can improve symptoms and have benefit in preventing hospitalization, as do MRAs. GLP-1 RAs can improve symptoms, and we're gaining more and more data about their benefit on outcomes.
If we were having this conversation 50 years ago, we would really only be talking about HFrEF, because the majority of the heart failure that was occurring in the population was after a heart attack or after ischemic heart disease had already developed, and the patient had a weak pump. And so that was the paradigm for many decades, and that's where all the treatment focus was. But in recent decades, we're actually seeing HFpEF start to supersede HFrEF in terms of the prevalence in the population.
There are many reasons why we think this is happening, but it is definitely happening. One of the big things is the aging of the population, but probably the number one thing is the global epidemics of obesity and diabetes. That metabolic stress, coupled with a sedentary lifestyle, which we're seeing more and more of as well, that's the perfect storm for heart failure with preserved ejection fraction.
In both patients and clinicians, there is a misperception that HFpEF is a less serious disease because the ejection fraction is preserved, but categorically it's not true.
HFpEF is the number one reason why people over the age of 65 are hospitalized, and we're seeing the numbers just go up and up.
We know that about half of patients who are hospitalized with heart failure are back in the hospital again in the next 6 months. And so thinking about what are the things and strategies that we need to implement to make sure that that doesn't happen is going to be critical.
It's not easy to diagnose heart failure with preserved ejection fraction. There's no one number that you can say, this person has that. You have to really take the whole clinical picture into account.
One of the other challenges is that there are so many other things that can cause the same symptoms: shortness of breath, fatigue, swelling. And many of the risk factors for HFpEF are common risk factors. Sometimes I think of the risk factors for HFpEF as kind of grouped into those that are cardiovascular or cardiometabolic and those that are non-cardiovascular, and then starting to think about, are there red flags or things to look for when someone presents with shortness of breath. In the cardiovascular or cardiometabolic group, we have longstanding hypertension, obesity, diabetes, coronary artery disease, atrial fibrillation, we have valvular heart disease. Almost all patients with HFpEF have hypertension. About a third to half have diabetes as well concurrently. So you can see there's common risk factors that can make you more suspicious. In the non-cardiovascular ones, these are perhaps ones that people are less familiar with for HFpEF, but are really important risk factors and are common, like chronic kidney disease, sleep apnea, COPD, but also things that are less common but can uniquely influence risk, like radiation to the chest after breast cancer or lymphoma.
The most important thing about HFpEF is to have a really high index of suspicion. If the patient has the risk factors and they're coming in saying, I'm short of breath when I exert myself, or they have a shortness of breath when they lie flat, they're having swelling in their legs, you have to have it in the back of your mind. Does this patient have HFpEF?
If you have a reasonable index of suspicion, the things you need to do next are get an EKG to look for left ventricular hypertrophy, measure their BNP, measure their kidney function, and then get some imaging. You're going to either rule in or rule out a lot of potential underlying causes, but you're going to help make the diagnosis of HFpEF when otherwise you might have just written this off as deconditioned.
The important thing is don't rule it out unless you're completely sure that there's another cause of their symptoms, because BNP may be normal, resting echocardiogram may be fairly normal. That doesn't rule out the diagnosis. So let's talk about how we make the diagnosis. The H2FpEF score is a really simple score that just requires a clinical history and an echocardiogram. But let me point out a few caveats that are really important. The echocardiogram has to be done with Doppler. Oftentimes it's not done with Doppler, or it's ordered as a stress echo without Doppler. Doppler is the way we really diagnose diastolic dysfunction and look at filling pressures and things like that. One of the criteria is 2 or more antihypertensive agents. When that score was developed, they included diuretics in that antihypertensive medication group. So any drug that can be construed as an antihypertensive in any way, including diuretics, are included. The other one is the pulmonary artery systolic pressure. So oftentimes on an echocardiogram, the pulmonary artery systolic pressure, which is the same as the right ventricular systolic pressure, can't be estimated. There's not enough tricuspid regurgitation. If that's the case, score that as a 0. They shouldn't get a point for that. Another criteria that gets confused is atrial fibrillation or flutter. Any history of that, they get those 3 points. Finally, the E to E prime ratio has to be greater than 9. So when you read the echo report, it might say septal E to E prime at the septal mitral annulus, lateral E to E prime, average E to E prime, any of those. If they're above 9, they get a point for that. That ratio, that number, is different than what's in the guidelines for diagnosing diastolic dysfunction. So people shouldn't get confused about that. This is specifically for HFpEF. Once they get the score, if the score is less than 2, the likelihood that they have HFpEF is exceedingly low. And I think that can be quite helpful. Now, if you had a patient with a score of 0 to 2 with a very high BNP, then something is going on and we need to investigate. If the score is 5 or higher, the likelihood of HFpEF is greater than 80%. So I wanted to tell you what we found. Obviously, we can't just take care of patients without thinking, and there are other scenarios, and people have shown that these scores aren't perfect, but they give you a sense that it's very likely, and I think treatment could be indicated.
Getting patients on optimal therapy as quickly as possible is extremely important. Yes, I'm going to start them on diuretic therapy if their volume is up, but I'm going to go ahead and start them on the SGLT2 inhibitor because we know patients do better on an SGLT2 inhibitor than they do not on one.
That score of 2 to 4, especially if the patient has unexplained dyspnea, that's where we need to figure out, is there further testing we need to do, or do I need to refer to a specialist? The vast majority of patients will have this sort of typical common HFpEF that's associated with hypertension, obesity, diabetes, chronic kidney disease, atrial fibrillation, coronary artery disease, that kind of HFpEF. But then there are other causes that we need to systematically at least be thinking about, because a lot of the other etiologies have specific treatments.
A lot of our HFpEF patients, we also like to evaluate them for a condition called cardiac amyloidosis. A lot of these patients can actually have a history of bilateral carpal tunnel syndrome. While it's not super uncommon to have a single-hand carpal tunnel syndrome, bilateral carpal tunnel syndrome with bilateral carpal release surgery should be a red flag. We also see a history of bicep tendon rupture. Amyloid deposits harden that tendon, so it basically just snaps. We've had patients who come in and say, I was just carrying my TV down the stairs and all of a sudden my bicep tendon snapped. If you're seeing this patient in a regular clinic, you're like, why did that happen? That is when we want their alarm bells ringing to further evaluate for a cardiac amyloidosis.
Other conditions like hypertrophic cardiomyopathy can often also cause symptoms like HFpEF, but is an inherited condition. It's important now that we have very specific molecular therapies for both of these examples, amyloid and hypertrophic cardiomyopathy, to better understand if a patient may have one of those that's separate from HFpEF.
Other things that can cause this syndrome are cardiotoxicity, radiation heart disease, sarcoidosis, constrictive pericarditis, valvular disease. Rarer causes can be Fabry disease and hemochromatosis. So it's important to understand that if the initial workup says that this patient has heart failure and they have a preserved ejection fraction, but everything's not adding up, or they don't respond to treatment, or the echo shows something funny, that we expand and we refer for a diagnosis.
I think really framing this as a modifiable and treatable disease is really important. The role that primary care clinicians have is such a critical part of identifying patients who may be at risk for HFpEF so that we can focus on prevention, but also in diagnosing it earlier, before someone's in the hospital, before they have advanced their disease to a point where there may be less potential for improvement.